All right, everyone. Well, we will go ahead and get started with our ultrasound case series presentation today. I have the pleasure of introducing Dr. Drew Duerson, who's a sports medicine physician at Nationwide Children's Hospital in Columbus, Ohio. He is the Associate Program Director for the Fellowship and Co-Director of the Musculoskeletal Ultrasound within the Division of Sports Medicine. He is also a Clinical Assistant Professor of Pediatrics at The Ohio State University. He does hold a registered musculoskeletal sonography certification through the Alliance for Physician Certification and Advancement, known as the RMSK, and point of care musculoskeletal certification from the POCUS Certification Academy. And today he's going to be giving us a case presentation on patellar dislocation.
Awesome. All right. Well, good morning. Like he mentioned, my name is Drew. It's great to be here this morning, and I feel very fortunate to be able to present again in this awesome webinar series. I'm a huge fan. I've watched every single one of these videos over the past 4 years, and some multiple times. And I actually checked this morning, and I think we have 101 videos now in this library. So it's just awesome. This is an important learning tool for myself early on, and now I often use these videos for teaching our fellow, our residents, and even medical students at times. So today we'll try and stick with the agenda like all the past presentations, but one of my big goals is to provide some new tips and tricks along the way that I don't believe have been mentioned on this series before. This is going to be a tall task because there's been so many great lectures on the knee, especially already. But for the learners watching this morning and all those watching later, hopefully you can pay close attention and come away with at least a few new ideas. No disclosures. Here's our objectives, our roadmap. So like all of these, we'll present a brief case and then spend a majority of the morning going through my anterior knee protocol that will be considered a complete diagnostic evaluation. This will include some structures from other regions of the knee as well. We'll look at images of both normal sonoanatomy and pathology along the way, and then we'll finish with a brief look at an example of my ultrasound report. And then hopefully at the end, here's some comments from the audience. This has really been where I've learned the most sometimes over the years. We'll start with our case. Our case is a 15-year-old male soccer athlete. He describes an acute knee injury during a recent game. He didn't know the exact mechanism of injury, but did feel like there was some type of twist and a possible pop. And then afterwards, he was unable to bear weight. He was helped off the field by the athletic trainer and provided crutches, and then seen in the emergency department shortly after. Radiographs were obtained there, and he was placed in a knee immobilizer and referred to our clinic. And then 3 days later, he presented to our pediatric sports medicine clinic. At that point, he was complaining of just diffuse anterior knee pain, still had significant knee swelling, stiffness, a lot of instability when he was out of that brace. Physical exam, large knee swelling, decreased motion, limited strength, extensor mechanism was impaired. He was guarding quite a bit still, but Lockman was felt to be negative, valgus and varus stress both negative, bounce home test negative, and still was essentially non-weight bearing. And that was really our exam at that point. We reviewed radiographs, which is always important in our ultrasound cases to look at comparison studies. And these were unremarkable, essentially, other than there were some hypertrophic changes at that medial femoral condyle that looked like it was more of a chronic injury, maybe from remote trauma. The radiographs suggested that there was a joint effusion and then possibly some thickening of the quad and patellar tendon. So at this point, we decided to proceed with our point of care ultrasound. So for cases such as this, I would follow mostly an anterior knee protocol, and we'll go through all of these structures, but we'll focus on the medial retinaculum and the medial patellofemoral ligament in its dynamic assessment. We'll see this as both a part of the anterior knee protocol and that medial knee protocol. And within this medial knee protocol, I will typically, especially in cases like this, use that protocol in addition to the anterior knee protocol, and then even look to the lateral knee if clinically indicated. And not listed here, but I would even consider some of the posterior knee structures, as we'll discuss later in the talk. And for the fellows watching, Here's the list of pathology that we need to teach you based off our recommended curriculum from AMSSM. And we cover most of this with the anterior protocols we see with the blue arrows. And then if we look under the optional pathology, we'll see that MPFL sprain with and without instability, which we'll cover in detail today. And if you include some of the medial and lateral protocol as well, you even get more pathology. So based off this protocol we go over today, you can really be able to identify a lot of these pathologies. So today's case is a pediatric patient. He is skeletally mature, but I thought this would be a good place to maybe mention some tips and tricks that I've found helpful in my pediatric practice. And for the folks in the audience that treat both children and adults, you know that when you evaluate a young athlete, it can be much different when you compare that to a mature athlete. And for this patient, and for a lot of my patients, it was the first time that they ever seen an ultrasound. So with that, there sometimes comes some hesitation, maybe some questions. So I think first and foremost, especially for our youngest patients, we want to reassure them that the ultrasound actually does not hurt. And I often refer to the transducer as a special camera. It's going to be very similar to the camera the doctors used when they looked at mommy when you were in her tummy, and they become very familiar with that. I think gel warmers can be a nice touch. The cold gel can catch kids off guards at time. And with that said, another little tip, I do keep some sterile gel in a refrigerator nearby for procedures where I need a nice gel standoff. Not necessarily this case. And then I think it's clinician preference, but I like to have my patients laying down and very comfortable for all of my procedures. And I like to do all my diagnostic scans in the same position that I'll do an interventional scan, and that's typically going to be laying down. I like to encourage distractions. So that may be a parent at the head of the bed holding a hand, or oftentimes a phone that the kid can watch or play a game on. And then lastly, I've found having a monitor on the wall has really been a game changer. I can project my ultrasound screen, and for those kids that are interested, they can still see what I'm doing from that laying position. But I think it often helps the parents from across the room. They can watch the scan in real time, and I can interpret my images and explain what I'm looking for and what I'm seeing. So now onto our case. So and we'll go through all the ultrasound findings here. So in this case, like a lot of these acute knee cases, one of my big questions is, where's the swelling coming from? And with ultrasound, we can easily answer that question and confirm our clinical suspicion. And like in this case, we thought there was most likely a joint fusion, but could there be something else, some other superficial swelling, such as a hematoma or a Morel-Lavallée lesion or bursitis? So I typically will start proximally and work distally. I'll start about mid-thigh and scan short axis and make sure I capture all four quadriceps muscle. And in this image, we can see the four quadricep muscles. The rectus femoris is going to be superficial, vastus medialis on the left of the screen, lateralis on the right, and then the intermedius deep sitting adjacent to the femur. And we can see that the rectus femoris and the vastus intermedius don't sit in the same imaging plane. So if one is bright, the other one won't be, and vice versa, as you're getting those nice reflections from the intramuscular connective tissue on one, but not the other. So this video will kind of demonstrate that as I toggle my transducer back and forth. And you don't want to mistake that cloudy appearance for edema, because that will often resolve with toggling your transducer. So I think that's one of the little key tips and tricks this morning. Also, maybe not so much in this case, but I'm going to be looking for fat atrophy, which will make the muscle look more echogenic, which has always been interesting to me, because muscle, by itself is hypoechoic, and when you look at fat, it's hypoechoic. But if you put the two together, it gives us a more hyperechoic image, and that's because now you've replaced that muscle tissue with fat, and we have more tissue interfaces with differences in impedance, so we get more reflections, making the atrophied muscle more echogenic. So now that we've looked at the muscle and short axis with some still images, then we'll go and do a short axis slide distally until we get closer to the distal femur and evaluate those muscles. So once we've done this kind of short axis survey. I do like to look at long axis, especially in this case, near that distal vastus medialis, as this would be a common location for pathology. So here is that long axis view of the vastus medialis and its insertion on the medial retinaculum. And we can clearly see in this picture that there's a discontinuity in that musculotendinous junction and a likely small hematoma there. So if we compare that to the contralateral side, which you'll hear me say often throughout this presentation, and I think is another key tip and trick here, especially in pediatrics, looking at the good side, you'll see how the two are much different. This picture is a slightly different image as we're seeing some direct attachments to that medial patella. So next is the suprapatellar recess. This is the scanning position that I use, not in this image, but I do like to use a bolster. This, especially in these acute knee cases, helps keep the patient comfortable because that extensor mechanism might not be completely intact. And if we can keep around 30 to 40 degrees of knee flexion, then we should be able to see this recess well. I found if we flex the knee too much, which we won't in this case, we start to see too much trochlear cartilage, and that can sometimes be mistaken for an effusion. But I think, as many of us know, fluid can easily be identified by its tendency to change shape with transducer pressure and movement of the joint. So we don't confuse that with articular cartilage or even synovium. And then, again, not necessarily needed in this case, but if you have a patient that potentially has an effusion, but you can't really tell, one little trick is to extend the knee and then provide an isometric contraction to the quadriceps. And this will essentially act as a vacuum and will suck the fluid from the knee joint. And you often will see that fluid track proximally deep to that quadriceps. So here's our patient. We see anechoic fluid between the more superficial and triangular shaped suprapatellar recess, which will be in yellow, and the deeper, larger, kind of more rounded prefemoral fat pad. And then this, obvious effusion in this case, but when you compare it to the other side, you can see the big difference. And this is the same image, but just short axis, and this will be just proximal to where we were seeing that suprapatellar fat pad. And this would be again, a good way to evaluate for effusion, but also looking for any loose bodies that could be hiding. And then if we compare that again to the contralateral normal side, we'll see there's a significant difference. And then another tip here is if you're looking for the recess in a dry knee, it can be challenging, especially if you're trying to do some type of joint injection. So if you push that fat pad lateral to medial, you should see the fat pads move and change positions and sometimes distinguish the two fat pads from one another, but the recess won't change position. So that's another little trick to be able to identify the recess when you have a dry knee. So here is a similar position, but this is what's going to give us the best view of the quadriceps. So I like to flex the knee closer to 90 degrees. This will add some tension to the tendon and help eliminate any anisotropy. In this case, it would be difficult to be able to flex our patient to this 90 degrees. And like, really all structures, but especially when we're looking at these extensor mechanism tendons, you want to make sure you evaluate the entire width and length of the tendon in both orthogonal views. So here is the image of our patient. The quadriceps tendon is most often described as a trilaminar structure. I find this is not always obvious though, and sometimes can look more bilaminar or even multilaminar, but the key here is you don't want to mistake that for pathology. In our patient, I think you're able to make out the three distinct layers. The deep is going to be in yellow, and that's going to be from the vastus intermedius, the middle layer from the vastus medialis and lateralis, and then that most superficial layer in red, the rectus femoris. And then if you look hard enough, sometimes even at that superior patella, you might actually see three different facets that correlate to these layers. So that's another little tip. Here's the same image, transducer rotated 90 degrees to get our short axis image. I found it a bit more challenging to see the three distinct layers, but if you look hard enough, I think you can even see those in our patient. And tendon looked normal to me. I did not see any thickening or any tear. So now we move more distally to the patella. I remove the bolster at this point, have the patient fully extend their knee and try to relax their knee. I'll use a copious amount of gel to try to evaluate the patella, both long and short axis. I'll pay close attention to that superlateral portion of the patella, as that is going to be the most common location for a bipartite patella. And then in this case, especially, I'll pay special attention to that medial patella to look for any avulsion injuries. Superficially, and the reason for the gel, we want to look for any prepatellar bursal fluid, and that can sometimes mimic a large knee effusion, so that would be on the differential here. And we can roll that easily out with ultrasound. And, the gel helps, but also just trying not to image with a heavy hand. Sometimes even using fingers as stilts for the transducer can be helpful in this position. So here's a long axis picture of our patient's patella. Shows no bursal fluid distension superficially. You can see that nice gel standoff, which is important. It can be a little bit challenging, but if you look close enough, I think you could see the superficial fibers of the quadriceps tendon is essentially in continuation with the periosteum of the patella. And then if you go more distally, the superficial fibers of that patellar tendon. So this really shows us that the patella truly is a sesamoid bone. And if we look superficially, we do see some soft tissue edema there in the yellow in those subcutaneous tissues, especially if you compare it to that contralateral normal side. So here's the transducer position for the infrapatellar structures. We'll be looking at the patellar tendon, tibial tubercle, Hoffa's fat, and infrapatellar bursa next. So I typically still like to keep at least that 30 to 40 degrees of flexion if possible, even try to get closer to 90 degrees, just based off the patient's comfort. Again, just like the quadriceps, puts more tension on the tendon and helps eliminate some of the anisotropy. However, if you're looking for small neovessels, I like to extend the knee, and that'll help remove some of the tension and help avoid any false negative Doppler scans for those smaller vessels, as that image shows there. And additionally, I like to use minimal transducer pressure here, and again, just copious amounts of gel that can help identify these small neovessels. So at this point, I thought it may be a good idea to demonstrate a little trick that I've learned over the years, essentially trying to best prepare your Doppler box to get rid of artifacts. So I start by turning to my settings. So the first thing I want to look at is find a known vessel. So for the knee, I'll usually look at the geniculate artery deep to the MCL, and then I can use that to adjust the Doppler scale. So if I have too much flow outside of that known vessel, too much noise, then I want to increase the range. As we'll see in this video, it goes from 3 centimeters per second up to 10, and we'll get rid of some of that noise, and we'll just see flow within that vessel. From there, we'll go back to the patellar tendon, and we'll adjust the gain on our settings. And essentially, we try to zero the Doppler box. So we crank up the Doppler until we see everything's bright, and then slowly decrease that gain back until we see the flow deep to the bony cortex, where we know there should not be flow, goes away. And then at that point, we have a nice zeroed in Doppler box. And if we make that Doppler box as small as we possibly can, that will increase our scanning lines within that box and also increase our chances of seeing these small vessels. So with all those things, now we have a nice, accurate Doppler box. So another tip to take with you this morning. All right, so now we've had a good look proximally. We'll move distal and look at the patellar tendon. So I often will do an extended field of view image to get the entire length, because you can't get that with just one transducer width. But in this picture, we'll just piece two pictures together, and we see a nice normal proximal tendon that looks, nice fibular, homogeneous, normal appearing. And then if we look at that more distal tendon, we start to see something that catches our eye. So we'll see some potential swelling in what I thought maybe be the superficial infrapatellar bursa, even though it's a little bit more proximal than where I'm familiar to learning that bursa to be. But I see it next to some of that adjacent subcutaneous edema. So from here, I want to look at that in short axis. And I think this is important, especially if you see something abnormal in long axis. And we see this focal kind of anechoic area in the superior medial tendon. There wasn't any pain with sonal palpation in this area, and it looked very, very, circumscribed. So my suspicion for a partial tear was quite low, but that was on the differential. But I use this mostly as a good example of why you need to scan the full width of the patellar tendon, because if you're sitting, very central midline, you may miss small, subtle irregularities like this. Even though I think for this patient, this really had minimal clinical relevance. And then here's the contralateral side, and it is the extended field of view image where we can see the full length of that nice normal patellar tendon. All right, and then deep to the patellar tendon, we'll have Hoffa's fat pad. I'm typically looking for two distinct layers here in the fat pad. Superficially, I often will see a more lobular appearance. And if I see more cloudy or edematous appearance, that will heighten my suspicion for impingement or some type of maltracking of the patella. And in this dynamic video, as we go from an extended position to a flex position, you can see some subtle movement of fat over that lateral femoral condyle, which is essentially normal in this case. And I think try not to present too much extra pathology today, but it was coincidence. I was putting this together, and on my social media page, I saw a nice post that I thought it was worth sharing. So I'll play this video. And here you can see a good example of Hoffa's impingement, which I think is frequently associated with lateral patellar subluxation and patella alta, which is important in this case. For me, I always, relied heavily on MRI to show that classic edema in the fat pad and some lateralization of the patella and patellar tendon. But, we can evaluate this very nicely with ultrasound, and we can see a mixture of findings. It's not just edema, but we can see sliding of that superolateral fat pad over the lateral trochlea. And then we could see some impingement of that between the trochlea and the lateral fibers of the patellar tendon. And then maybe even a snap, which I think this video demonstrated very well. And then while we're on the topic, I thought it would be a good idea to give a shout out to some good social media pages that I have really appreciated over the years. I've learned a lot from these folks. I don't know them, but I wanted to draw some attention to them. So maybe, especially some of the fellows on the webinar this morning, could jot these names down and give them a follow, because I think not only do we have great resources like this webinar series and this library, but there's a lot even on social media that you could learn from. And now back to our case to finish out the infrapatellar structures. We go quickly back to that potential infrapatellar bursa that we touched on, and this is where I'll be interested to hear maybe some comments from the audience to see what their thoughts on. I personally can say over the last decade of scanning in my pediatric population, I've not seen much, if any, superficial bursal fluid. So I'll be interested to hear what people think of this. And now we move back up proximally just a bit, and we'll focus our attention on the very important patellofemoral joint. So here's the position for the lateral retinaculum and the patellofemoral joint. In our patient, we can see some fluid distending that lateral joint recess, no loose bodies. The overlying lateral retinaculum is intact, which is often the case, as seen in red here, unless the patient has a history of a lateral lease, which is a common procedure in patients with chronic recurrent patellar instability. So you want to take a look, especially in this case. And then again, have the contralateral side to compare, and we can see what normal looks like. Nearby, we can evaluate the tibiofemoral joint and the anterior horns of the medial and lateral menisci. This is the position for the medial and lateral meniscus. One trick that I found is try to always angle your transducer to a central point within the middle of the knee joint. That really helps me best see the menisci. Otherwise, I think it sometimes can be a challenge, especially for that lateral kind of deeper meniscus. We'll first look at the medial knee. Here's the medial menisci. No obvious anechoic clefts or tears, extrusions, or cysts. Then we can see the lateral meniscus here. And I think you got to be careful not to call this anechoic signal a tear. To me, this more likely represents a penetrating vessel. So if we use Doppler, we can identify that nearby vessel, which we also don't want to mistake for a small cyst. Here's the typical position for me to look at the distal femur and the trochlear cartilage. However, in this case, like many of the acute knee cases that we see, it's just really impossible to get the patient in this much knee flexion. But quickly, to look at a normal knee, this is what you should look for. Nice uniform anechoic signal on top of that trochlea, typically around 2 millimeters in thickness. We know that the lateral side is typically a bit larger, so it's more superficial in the picture, so it's easy to identify. And then in this picture too, you can see the distal fibers of the vastus medialis too, as it's going to be the most caudal of the quadriceps muscles, and sometimes even have some direct attachments to the patella. So for our patient, we had to look for that trochlear cartilage with the knee extended. So we can do that by adjusting your settings a bit. You may have to add some depth, decrease your frequency, and possibly even use that time gain compensation. But I think if you tilt your transducer and kind of slide laterally, you can visualize more and more of the articular cartilage as we go. And these pictures will be kind of subsequent images starting midline and angling laterally and then sliding laterally. And then we get a pretty nice picture of the articular cartilage there in long axis. And this patient's cartilage looked normal. And finally get to the most important part of our exam. This is going to be the medial patellofemoral joint. And I intentionally did not go straight here with this case or really any of my acute knee cases. And I think it's been said on here, many, many times, but you don't want to go straight to where the money is, and you want to, do your best to stick to a protocol and try not to miss anything. So here's the transducer position for me. And this is the image of the patellofemoral joint and the overlying retinaculum. Admittedly, it was even difficult for me to draw these accurate lines over this kind of very, abnormal appearing retinaculum. It was thickened, heterogeneous, and had some discontinuity to it. Deep, again, we see in yellow there our medial recess with some fluid distension, no obvious loose bodies yet. And we compare that to the normal side, we can see a big difference. And then from here, we'll scan proximally to try to find that medial patellofemoral ligament, which becomes the focus of this exam and really an interest of mine over the years. And I'm glad we're, finally discussing this pathology today. I think we've briefly touched on it in the past, but really there's no clear recommendations on how to scan this area of the knee. So, for me, I really turn to the literature to help come up with a plan. So I'm hopeful these next few slides will provide the audience with some resources that they can turn to as well. So what I once thought was just simply a thickening of the medial retinaculum, and always heard about the adductor tubercle, it really seems a little bit more complicated than that. And in this 2017 review from the journal Orthopedics, we find a nice discussion on the complexity of the MPFL. We know that the MPFL is the primary soft tissue restraint for lateral patellar instability and can be injured up to 95 to 100% of the time with these acute patellar dislocations. But what was the real anatomy of the MPFL? And in this review, we look at 9 cadaver studies. And from this table here, we can see that the patellar attachment is relatively straightforward. Most studies see the attachment at the upper portion of the patella, anywhere from the top half to 2/3. But it's the femoral attachment, on the other hand, that has a lot of variability. And it, typically found near that medial epicondyle, but it has some varying relationships with the adductor tubercle, proximal medial collateral ligament, posterior medial capsule, even the adductor magnus tendons. So we know that the ligament's important. We know that it can look different from patient to patient. So big question is, can we see it with ultrasound? And this study is from a while ago, 2003, one of the earliest studies that I found that really tried to answer this question. This was a small observational study, just 10 cases that presented to the emergency department and had a ultrasound scan, and they all went on to surgery. They were able to compare those ultrasound images to surgical findings to see what the usefulness of ultrasound was. And this was really the first study to really describe some of the sonographic findings that we're going to go over. Tears of ligament, vastus medialis, swelling around the medial collateral ligament origin, hematomas. So I add this mostly to show how long we've been doing this exam, over 2 decades now, and then really how far we come. If you look at that image, our technology is so much better where we can now really see this part of the knee very well. Next question I had is, there's variability, and we can see the findings of a patellar dislocation even 20 years ago, but how does this compare with MRI? And this study's from 2015 from the European Radiology Journal. It was a prospective study, close to 100 patients, that compared ultrasound with MR, really trying to detect partial versus complete tears in acute patellar dislocations. And in this study, we see similar sensitivity, specificity, and accuracy of both of these modalities. So it appears that ultrasound does do just as well as MRI when looking at these patients. And then next we could see, sorry. So we can see it on ultrasound just as well as MRI, but maybe even better, I would argue. So what else can we learn? And in this case, from this paper, looked at around 50 cases. We can see that that when we're looking at acute patellar dislocations, it doesn't really matter if it's patellar sided or femoral sided, even though I often would look just to the patellar side. It is more common to see this on the femoral side, but the degree of osteochondral injuries didn't really matter where the location was. The only thing that this study really provided, and not a huge surprise, if there was a complete tear of the medial patellofemoral ligament, it does increase our chances of having an osteochondral lesion. So that would therefore make you want to pay close attention to that part of your exam. And then lastly, what about the dynamic component? How could this really help us? In this recent study from 22, it was a controlled laboratory study. They looked at 10 cadaveric knees and were able to identify the optimal threshold for identifying a tear. And they used a number of 20 degrees of flexion and around 2 centimeters. So if we're past 2 centimeters, then that helps us identify the medial patellofemoral ligament injury. All right, so now we move to my approach to the MPFL. This first video will show my technique of identifying the ligament. I'll start kind of midway at the patella and move proximally until the patella drops out of view, and then come right back until I see the top portion of the medial retinaculum, that thickest portion, and then I'll scan laterally over towards that adductor tubercle, knowing that there is some variability there now, so this may take a couple attempts to be able to visualize that. The second video will be my dynamic scan, where I've found my medial patellofemoral ligament, and I'll want to provide some lateral stress to the patella to see if there's any instability. This will help me differentiate between any partial and complete tears. And then also providing a little downward pressure on the lateral patella, that will add some tilt to the patella, and I'll be able to better see that medial facet, which we can already see better than the lateral facet, but with this provocative maneuver, we can see it even better. So this first image will show the abnormal appearing MPFL. We can see in the red outline that it's very abnormal, thickened. There's some discontinuities. This ligament often does look bilaminar. If you look at that proximal attachment near the patella, you'll see that there's some fluid between those two layers. And then in yellow highlighted, looks like they possibly have a couple of avulsion injuries as well. And then if we compare that to the normal contralateral side, we'll see a nice normal kind of uniform thickness of the MPFL as it goes over in this extended field of view image closer to the adductor tubercle, where we now could see the medial collateral ligament in short axis. And then here is a video of that dynamic maneuver where we're putting some lateral stress on the patella. And I think this is very helpful to see how much instability of that patella we really have, but also help us distinguish between partial and full thickness tears. And in this case, while I do feel like there were some partial tears at the patella and femoral attachment sites, I did not appreciate any full thickness tears or gaps when I did this provocative maneuver. And then in the still image, we can measure the distance between the medial patella and the medial trochlea. And our patient measured over 3 centimeters. So if we go back to that one paper where they used to cut off around 2, we could see that this patient did have some increased distance there. Like most things today, I want to compare that to the contralateral side. We don't have great normative values for pediatrics, and that's the case for a lot of what we do. So you always want to compare to the other side. That can become a challenge, though. A lot of these kids will have bilateral issues or some hypermobility of both patellas. So that comparison gets even a little bit more tricky. So I would argue that the most important thing is just evaluating the appearance of the medial patellofemoral ligament as we can see it so nicely. And then here's a video of that tilt maneuver. So if you're putting some downward pressure on the lateral patella, we'll see the patella tilt a little bit. And if we angle our transducer with a little heel toe maneuver, now we can see the articular surface of the patella. And outlined here in yellow, we see nice normal anechoic articular cartilage, and then unfortunately a pretty abrupt disruption in that articular cartilage, and it looks to be a focal defect in that articular cartilage, which is a nice thing to be able to see on ultrasound. Admittedly, you cannot always see that, and would be a big reason that we have to turn to MRI in a lot of these cases, but in this specific case, I was able to actually see the articular cartilage well. And then here's a extended field of view image, not necessarily in your protocol, but kind of a nice picture to at least try and practice. And for those that are not familiar with ultrasound, this may help them visualize that patellofemoral joint a bit better. So now to finish up the protocol, we'll go over some more optional structures. And this will be really just based off your clinical suspicions. But here's a video of how I would attempt to find the saphenous nerve and attempt to follow the infrapatellar branches. Start kind of mid-thigh and identify the sartorius and the superficial femoral artery. Look for the branch that will come and then eventually sit superficial to that sartorius and its fat pad. And then it makes a turn kind of more laterally and anterior to the patellar tendon and Hoffa's fat pad. Another study that I thought was helpful when I was, trying to learn this scan, I think is pretty difficult. So again, just a resource for the audience today to go back and look at it. I think it gives us a nice protocol to be able to visualize this nerve. And beyond the scope of today's talk, but hopefully this would be, sparking some interest for some of the audience where they could maybe present a nice case of some pathology to the infrapatellar branch of the saphenous nerve so we can all learn. And then here's our patient. Here's a video of Doppler trying to find that superficial femoral artery. And then from there, being able to identify the nearby saphenous nerve. And then if we follow that distally, getting closer to the tibiofemoral joint, we'll be able to find those smaller infrapatellar branches. And now another topic that I'm really not, strong at, but I think it's something worth talking, especially about in these acute knee cases. It's the anterior cruciate ligament. So best seen if we can flex the knee, which is, part of the problem in this case. You can't flex the knee enough to see it, but you can potentially try to see it in an extended position. And this is our case. You start over the patellar tendon, and then you want to angle your transducer a little bit more medially with the caudal end, and then that cephalad end is going to be a little bit lateral to the tendon. And I think key here, if you're looking for the anterior cruciate ligament, you want to keep your eye in Hoffa's fat pad around 2 centimeters deep, and look for the hyperechoic intermeniscal ligament, that transverse intermeniscal ligament. And if you find that, then if you go just deep to that and nearby, you should be able to find the tibial attachment to the ACL. And I will admit this is easier said than done, but hopefully this again will maybe spark some interest for those in the audience that we can maybe present a good case on this. I think probably more important for our chronic patients that have unstable knees, where we can be able to flex that knee and look at that ACL attachment. Again, just another good resource. They make it look easy. They have some nice videos that they've published, even being able to distinguish the two main bundles of the ACL. So just another resource for you all to go out and watch. Now moving on to the medial knee. Again, I will often include this in my anterior knee protocol. This will include the medial collateral ligament. And this will be the position that you'll want to use. We know that the MCL is a very broad, long ligament. So to be able to see its entirety, you're going to have to do a nice long axis scan to be able to see that. And then here's our patient. Fortunately, they had an intact MCL, and we were able to differentiate the superficial fibers from the deep fibers here. And those were intact. And I think I don't do it always, but it is important to consider a dynamic scan in this scenario. And especially if you see any pathology to that medial collateral ligament. And the way I essentially do it is I'll have my hand that's holding the transducer. I'll have their lower leg essentially in my armpit, and use my body as a way to move the knee, and then the opposite hand will be my fulcrum, and that's the position I'll take to provide that valgus stress. As we scan the distal MCL, we will see the medial, more of the medial knee, and we can identify the pes insurine tendons, and we can see the sartorius, gracilis, and semitendinosus, and say grace before T is the mnemonic that I've always used as we go proximal to distal. This picture actually gives us a long axis image of one of those tendons. In yellow, we'll see a short axis picture of the medial collateral ligament, and in between the two, I do not see any bursal fluid. So again, if you've got a swollen knee, one of those bursa that you might want to take a look at. I often look here but don't see bursal fluid. The ones that I've seen more recently have been direct trauma to this part of the knee and related to some type of MCL tear, which this patient did not have. And then lastly, here in the anterior portion, I add a little bit of the lateral knee. Often we'll look at the iliotibial band, as its distal attachment on Gertie's tubercle is quite anterior, especially if the patient felt some type of pop and had some swelling in this area. I think it's worth looking at the distal IT band, and it's easy to find. This video will show you how to find it. You start with your patellar tendon and then just slide laterally. Once you lose the patellar tendon, you'll eventually see Gertie's tubercle, and the next fibular structure that appears on your screen will be the IT band. And then here is an extended field of view image of the iliotibial band in our patient, and it was normal, uniform thickness, no tear, no bursal fluid. And then here's a dynamic video of how you can assess for any snapping. So essentially, just flex and extend the knee. Sometimes have them even sit on the edge of the table to make that a little bit easier. And you can see nice smooth gliding of the IT band over that lateral femoral condyle. Did not see any dyskinetic snapping. Again, no bursal fluid deep. And then finally, again, like I said, not always, but maybe even looking at the posterior knee. I think this is not my routine, but if I've looked at the entire anterior knee in an acute knee injury with a traumatic effusion, and I don't have a quick answer, I will, then turn the patient over and look posteriorly. And I think finding the PCL is much easier than the ACL. And the trick here is if you find the tibia, it's going to usually be a little bit flat and kind of squared off, and then you slide to the midline, and you'll see a change in shape of your bone, and then you can identify the facet where the PCL attaches, and just like all our tendons, keeping the bony landmarks nice and bright will help you be able to see that PCL attachment. And if you're seeing any thickening there, that might increase your suspicion for this type of internal derangement and maybe a potential answer for why the patient has a knee effusion. And then no picture here, but also if I'm looking posterior, then I'll potentially look more posterior medially and try to look for a Baker cyst, as often we'll see that if there's a large knee effusion. And this, again, could be a potential space where a loose body could be hiding. Here's that PCL. And finally, we get to our report. So here's an example of what my reports look like. For the sake of time, I'm not going to read through this, but like most people, we want all the correct demographic and clinical information. I think it's important to mention our comparison studies. For my patients, which are mostly under the age of 18, I have a short blurb about teaching to make sure that everyone is comfortable and have consent to do the procedure. And then as I go through the description of the protocol, I'll have headers for each section, and then in sentence form, I will describe each structure. And I won't try to make any diagnoses in the actual body of the report. I'll save that for the end. But this is, just how my mind thinks and how I organize things. And then my impression will be at the end, and that's where I'll really make my diagnoses. And I'll try to list the most clinically important at the top, and then from there go in descending order, as I know most people will do the same thing like I do and go straight to the impression. But for this patient, essentially, we have sonographic evidence of a recent lateral patellar dislocation with a partial tear of the medial patellofemoral ligament with some laxity and increased medial patellofemoral distance, and also some focal patellar articular cartilage injury and a possible loose body. Patient had a large knee joint effusion and then had this possible small focal patellar injury versus some infrapatellar bursal fluid distension. And that essentially is my report. And with that, I come to an end. A quick blurb here. We have a conference coming up. We have this annually, and we'll be going over the lower extremity and some of these topics in our ultrasound workshop. And we have both skeletal mature and immature patients. So if you're in the area and free, you might stop by. And then we'll end with hopefully some comments, and not mandatory by any means, but if you got a camera and want to snap a picture of this QR code, that will lead you to a drop-down list. And if you pick my name, you can give a quick evaluation. I think it's always helpful to try to figure out how we can do these better and how I can work on my presentation. So if you got a few extra minutes, that's much appreciated. So thank you for your time this morning. Hopefully we're able to give you a few tips and tricks along the way that you can take with you, and look forward to any questions or comments.
All right, Drew, thank you. Thank you so much for that detailed presentation. Just some great images, I think, throughout the knee, as well as then those kind of helpful tips. I don't see any specific comments or anything right now in the chat. So I'll just go ahead and kind of give some comments of my own and kind of thoughts for discussion. As you had mentioned, with these injuries, I think it is very helpful and useful to use ultrasound, just in the sense that, some of these patellar subluxations, you may actually not involve or injure the MPFL. And during those cases, they can definitely sometimes have some different management. But the more we're learning that, I think if you do have complete disruption of that MPFL, and you can identify that fairly early, that is going to be a game changer, for management. And so obviously with ultrasound, just having access to this easily in clinic, having easy access to this, both on the sidelines and training room, I think this can definitely be, very helpful to kind of guide management, especially early on. And obviously, if you are seeing kind of major disruption of the MPFL or any concern for an intra-articular injury, then obviously you can go ahead and get the MRI in those cases, which obviously might be a little bit more timely. But in those cases where there is a significant injury, it may be one of those that you can continue to manage conservatively and get those athletes, back to return to play quicker. Other things to kind of just make comments on, for the protocol, as you had mentioned, you can include a lot of different structures. I think when you're evaluating a patellar dislocation, obviously most of the time I'm going to be going to the anterior knee, as you had described throughout the presentation. But obviously, depending on what clinically is indicated, you can continue to add structures, as you had mentioned, both in the medial lateral as well as in the posterior knee. So as you had kind of demonstrated, throughout the presentation, just include those and be aware of those, as clinically indicated. With specific regards to the MPFL, injuries and kind of little clinical pearls, obviously, for those you had mentioned, typically that is going to be most injured along that kind of medial femoral condyle, where that ligament attaches to at its origin, but can be injured less frequently at the patella itself. Some of the things that you had already demonstrated, with your images is that you can have some of those kind of secondary signs. And if you're ever seeing a suprapatellar recess effusion, obviously I'd have a very heightened awareness that you're more than likely going to have MPFL tear if they do have that history of a patellar subluxation or dislocation. One thing to note with those suprapatellar recess effusion, which I think some of your images showed, sometimes it can just be, clearly anechoic fluid, which may just be synovial fluid, but sometimes it may become a little bit more hypoechoic or even mixed echogenicity. And in those cases, that's going to tell you that that's potentially a hemorrhagic effusion, within the knee, just demonstrating potentially there is going to be ligamentous involvement. The other is that occasionally you can actually get, a lipohemarthrosis as well too, which is going to give you a triple layer sign on that suprapatellar recess effusion, and that's going to be indicative that you may additionally also have a fracture, associated with it, which obviously in some cases you can get with these patellar dislocations. And typically with that triple layer sign, what you're going to see is that the bloody layer is going to be deepest, then you'll get the synovial layer in the middle, and then the adipose layer, which is going to be most superficial at that area. And then I think the last thing which you had demonstrated, fairly nicely in this for these MPFL injuries, obviously the severity is also determined if they're going to be having, cartilage damage and involvement for these. And typically the two most common places that you're going to be seeing is along that kind of medial patellar facet, which is what you saw in this case. But you can also typically will get it along that lateral femoral condyle. So you had mentioned, I mean, it is going to be tough in some of these acute cases to be able to manipulate that knee to see that cartilage, but as much as you can, that can be very helpful and actually, guide management as well too, because obviously if they not only have that ligament injury, but also an underlying, cartilage or chondromalacia injury associated with this, obviously that might guide you a little bit more to go ahead and get the MRI, in these cases, which may need surgical management. Two things I was going to bring up as far as the images. You had mentioned that finding along the patellar tendon. Did that have that collection? Did it have any compressibility at all to that area, Drew?
Yeah, so when I was looking at it in long axis, yes, that fluid that was just superficial to the tendon did have some compressibility to it. So that, again, heightened my suspicion that that might actually be some infrapatellar bursal fluid. When I
Okay.
was looking at it in short axis, though, and I saw that nice, well circumscribed kind of focal defect in the tendon, that didn't have as much compressibility to it. So that,
Okay.
again, is where some of my confusion lied.
Yeah, I was almost wondering that we've had one or two cases in the past that you can get these intratendinous patellar tendon ganglion cysts.
Yeah.
I didn't know with this athlete if he was obviously doing a lot of overuse, to that area, but obviously that's where kind of the compressibility sometimes can be helpful. But just looking at that, that was just one thought, because as you had mentioned, is a little bit unique, location at that area. So something to maybe, think of or in the differential at least for that finding.
Yeah.
And then the last thing I was going to bring up, so the you had mentioned a loose body for the I think it was along that medial patellar facet cartilage. Did you think that that was more just damage, or do you think that that had actually kind of broken off and was going into the recess area?
At first I thought, it looked potentially bony. It didn't cast a big shadow. I didn't see a clear donor site. That articular cartilage defect was nearby, but it didn't look necessarily like cartilage to me. So full disclosure, this patient did go on to have an MRI, which I didn't include in this ultrasound talk, but um, did identify the MPFL injury, did identify the articular cartilage injury, but did not have a loose body. So I think that was probably just related to the injury to the medial retinaculum and MPFL. I did not identify an obvious loose body on the MRI.
Okay. Yeah, because that's what I was gonna say is that, I mean, definitely you could see the cartilage, damage, at that area, which you can get with these dislocations, but not always will then you actually have a piece of that hyaline cartilage that will kind of, break off. But as you had mentioned too, you can get those periosteal avulsions, off the either the medial femoral condyle or the patella itself as well too, which may not always involve, the cartilage as well too. But those are always, good secondary signs that we'll see for other ligamentous injuries as well too. So, but I think those are kind of the last of my comments. Otherwise, then once again, I really appreciate the detailed overview of this topic. Sure appreciate it.
Thank you. It was fun.